Growth hormone abnormalities will be discussed in this section. The growth hormone abnormalities can be either due to the deficiency of the growth hormone or the increase of the growth hormone. Then the growth hormone deficiency will result into the short stature, while the excess of the growth hormone can lead to the two conditions. It can either the acromegaly or the gigantism. It will be discussed later on in this section. So this section 2 is basically of growth hormone abnormalities, including the inherited isolated growth hormone deficiency, which is a respective type of the growth hormone deficiency, the growth hormone insensitivity, that in which the persistently increased level of the growth hormone results into the down regulation of certain receptors, resulting into the growth hormone deficiency. And then there is basically the comparison or the difference between the gigantism and the acromegaly, that how these two things are different. In both of these conditions, the growth hormone is basically increased. There is excessive release of the growth hormone. So now we will see that how these things are happen. So the inherited isolated growth hormone deficiency, there are basically the three types. The type 1A and the type 2 is basically caused by the mutation in growth hormone gene 1. So the faulty gene in type 1A and type 2 is the growth hormone 1 gene. In type 1B, there is the growth hormone 1 or the growth hormone regulatory hormone, which is denoted by the GHRHR gene, is affected. While in the another type, which is the type 3 of the inherited isolated growth hormone deficiency, the BTK gene is basically defective. This BTK is the Bruton's tyrosine kinase gene, which is basically responsible for the DNA binding, and then it has another function also. This gene is defective, which is responsible for the inherited isolated growth hormone deficiency. In this is basically the inherited disease, and this is isolated growth hormone deficiency. No other hormonal involvement is there, no other gland or no other thing or other abnormalities are there. It is just the inherited growth hormone deficiency. Then there are the certain mutation targeting the transcription factors, which will lead to the abnormal transcription and resulting into the mutation which presents with the growth hormone deficiency. These mutations can be either the PIT1, which are these mutations caused by the combined pituitary hormone deficiency. The combined pituitary hormone are deficient in the PIT1, the low levels or the absence of the growth hormone, prolactin, and the TSH. So what is the basic mechanism? That initially in the PIT1, the mutation is caused by the combined pituitary hormone, and which results into the low level of the growth hormone, prolactin, and the TSH. The PROP1-5q mutation is mutation inactivate basically the LH, FSH, growth hormone, prolactin, and the TSH. And at this stage, you all know that whenever there is the deficiency of the LH, FSH, they are unnecessary female hormones which contribute in the menstrual cycle as well as in the pregnancy. So whenever these are deficient, the patient can be present with the amenorrhea. When there is the growth hormone deficiency, there is the short stature, and the prolactin, it can when there is excessive release of the prolactin, it will result into the prolactinoma. The TSH, if there is increased in the amount of the TSH, basically the patient presents with the hypothyroidism. The TSH is increased and the T3, T4 will subsequently decrease, and the patient presents with the hypothyroidism. Basically, this is the autosomal recessive. Now the other is the HESX6-1 gene. This mutation cause problem is basically the septic optic dysplasia. That there is a compression of the optic chiasma which leads to the septic optic dysplasia, and then there is another syndrome, the Pickard syndrome. In this, there is also the TSH and the ACTH is also deficient in this. The other type is the PITX2 mutation associated with Rieger syndrome. LX3 and LX4 mutation are linked with the growth hormone, LH, FSH, TSH, and the prolactin deficiencies. growth hormone insensitivity or Laron syndrome. In this, basically these receptors are defective. There is a down regulation of the growth hormone receptors, and the patient presents with the short stature. Most commonly, this type of picture the patient present with the patient can be either obese, or there is the high level of the serum growth hormones, or the low concentration of the insulin-like growth factor 1 due to the greater growth hormone GHR mutation. Growth hormone insensitivity and Laron syndrome. The clinical presentation is basically the heterogeneous, and the treatment is basically with the insulin growth factor 1, which basically mimic the action of the growth hormone by binding to the respective receptors. There is a lower incidence of the cancer and diabetes in this, because the growth hormone, the amount of the growth hormone is appropriate, but there is the down regulation of the receptors, resulting into the clinical picture or the clinical symptoms of the growth hormone insensitivity. The growth hormone deficiency, the patient most commonly present with the short stature. There is diminished muscle mass, increased fat mass. There is increased level of the LDL cholesterol. As you all know that LDL, the bad cholesterol, it is considered as the bad cholesterol because it carries all the cholesterol towards the heart, and the HDL is considered to be the good cholesterol. So in the short stature, secondary to the other problem, there is the LDL is also increased, which is the bad cholesterol, which can manifest with the other cardiac diseases or the atherosclerosis. Then there is the decreased bone mineral density. These patients are more prone to the fracture, or if there is a little bit of the trauma or the pressure is applied, there can be a fracture of the bones. There is the diminished sense of the well-being. The patient basically feels sick all the time or deterred. The social circle is mostly affected, and the patient prefer to be isolated, to remain home, or to just hang out with some of the close relatives. Basically, there is a social withdrawal. It is another the clinical as well as the psychological presentation of the growth hormone deficiency. Now, the other clinical features, as in this diagram, you can see these all are the clinical features of the short stature. The patient presents with the low hairline. Then there is the chest shape is. Then there is a characteristic chest shape, the barrel shaped, and the nipples, they are widely separated. And in the heart, there is basically the coarctation of the aorta. Then the metacarpal, they are shortened. There are small fingernails. You can appreciate in this picture also. Another thing is that brown spot, which is known as the nevi, they can also present on the lower extremities as well as the upper extremity or the central part of the body, but most commonly they are present at the lower extremity. Then there are the certain facial characteristics. You can see in this picture also, in this diagram also, that there are coarse features. The coarse facial features are the hallmark of the short stature. The fold of the skin, there are thickened skin of the neck, and there is a coarctation of the aorta. Poor breast, the breast does not develop to the appropriate size, and there is the elbow deformity. This angle of the elbow, the carrying angle, it is basically defected in this. And then there's the ovaries, they are also defected. There's the amenorrhea, there's certain menstrual problem in this. The puberty is also delayed in the patients of the growth hormone deficiency or the short stature. Now coming back to the other topic, which is the growth hormone excess. Up till now we have discussed the growth hormone deficiency. Now the growth hormone excess. The growth hormone excess can present with two conditions, either the acromegaly or the gigantism. The acromegaly, the patient develops the symptoms of the acromegaly that when the growth hormone concentration is increased after the fusion of the epiphyseal cartilage of the bone. After that age, if if the growth hormone secretions are increased, then the patient will present with acromegaly. While in the gigantism, the growth hormone is increased prior to the fusion of the epiphyseal cartilage or prior to that age. So there is the abnormally increased elongation of the bone, the height is increased. So now we will discuss the acromegaly and the gigantism one by one, and then we will compare the acromegaly and the gigantism. The most common presentation of the acromegaly is again with the headache. Then there are certain visual defects that the patient can present with the photophobia. Dental bite disturbances are there because the lower jaw is increased, and then there is certain frontal bossing is present. All these are basically the hallmarks of the acromegaly. If you see the face of the patient of the acromegaly, you can easily diagnose or easily pick out that this patient is basically suffering from the acromegaly just by looking at the face of the patient. As you can see, there is a frontal bossing, the supraorbital bulging is there, the enlarged nose was there, the ala of the nose, they are basically widened, tongue and lip swelling is present, which contribute to the difficulty in the swallowing, and sometimes the breathing problems can also be there. And then there is the thyroid hypertrophy. Skin tags are usually present all over the body, glatoria, increased sweating, as well as the hypertension. All these are basically the clinical symptoms of the patient of the acromegaly. There is the enlarged feet, another thing. So the key point is, first of all, you look at the face of the patient along with the hands and the feet. You can easily pick up the patient of the acromegaly. Now the gigantism versus acromegaly. In both there's the headache, visual changes are there, visual disturbances are there. But as I have already told you that in the acromegaly, the growth hormone excess is after the fusion of the epiphyseal cartilage, and in the gigantism, they are prior to the fusion of the epiphyseal cartilage. In the patients of the gigantism are mostly abnormally tall as compared to the acromegaly. They can also be tall, but in the gigantism, the height of the patient is remarkably increased, while in the acromegaly, the bone density, the width of the bone or the jaw, they are greatly increased. So by looking at this, you can differentiate between the gigantism as well as the acromegaly. Usually the patient of the gigantism, they are thin, lean, and tall, excessively tall as compared to the acromegaly. So coming to the most important point in any disease is the diagnosis. And so the diagnosis of the short stature is made by assessing the growth hormone. To know that the growth hormone is basically the unstable hormone, and its half-life is very less, approximately of the 20 minutes. So by estimating the growth hormone in the serum, you cannot detect that the patient has the growth hormone deficiency or not. So there are certain other tests, other specific tests which are carried out to diagnose the patient of the short stature. There are the insulin growth factor 1, which is responsible for the mutation, responsible for the short stature, and these insulin growth factor, they're more stable than the growth hormone. So these levels are more helpful in the diagnosis of the short stature. Then there is the certain karyotyping for different syndromes can be there, or the early sexual characteristic. You have to take a detailed history from the mother or the patient, that whether the developmental goals were achieved on the time, or there was the developmental delayed, or then you can compare the height on the growth charts, that whether it falls below the 3rd percentile or gives you basically the exact picture. So diagnosis start with the detailed history. Then there are the growth hormone levels, but they are of less diagnostic value. Why? Because they are unstable and their half-life is decreased. The other tests are the insulin growth factor. These are the specific type of the protein. They can also be assessed. Then there are the certain stimulatory tests as well as the inhibitory tests. Keep in the mind that whenever there is a deficiency of any hormone, you perform certain stimulatory tests. And when there is the excess of any hormone, then you perform the certain inhibitory tests. The certain stimulation test will be and the inhibitory test will be discussed later on in detail. So to assess the short stature, up till now we have considered that you have to take the detailed history along with the growth hormone levels and other. But the other things are the baseline investigation. Never forget the baseline investigations. If a patient presents with any disease, you have to follow a certain protocol of the baseline investigation. In these you have to perform and respective to the short stature, you have to perform certain minerals, certain vitamins. These are of great importance: the serum albumin, the ferritin, and the B12 levels. These are basically to rule out the malabsorption syndromes, and the free thyroxine to assess the thyroid status of the patient. And then there is the cranial imaging with the CT scan or the MRI. They are useful for the tumors of the pituitary, which are the main cause of the hypopituitarism or the short stature. Karyotyping to assess the mutation, to assess the specific mutant, which is specific gene which is faulty. You perform certain karyotyping. Now coming back to the investigation for the growth hormone deficiency, as I've already told you prior that whenever there is a deficiency of the hormone, you perform certain stimulatory test. So the basal growth hormone level is first assessed. Then the stimulatory test or the stimulation test, they include the exercise stimulation test and the levodopa. Levodopa is basically a drug. Appropriate dose of that drug is administered IV. Then we see the response of the growth hormone. So in the investigations of the growth hormone deficiency, what we will do, first we will perform the basal growth hormone level. Then we ask the patient to exercise for the 20 minutes, and then we again reassess the growth hormone level. If there is the increase of greater than 20 milli-international unit per liter in the respective patient, then we can say that the patient has the growth hormone. If a normal response is basically 20 milli-international unit per liter. If any response less than 20 milli-international unit per liter is there, then we label the patient as the growth hormone insufficiency or the growth hormone deficiency. Then there is the levodopa stimulation test, in which the dose is 0.5 gram per 1.73 meters square. This 1.73 meters square is basically the body surface area. So the samples are taken at the interval of the 30 minutes. The initial sample is taken at the 30 minutes, then 60, 90, and 120. Again, the normal response is greater than 20 milli-international unit per liter. Now the investigation for the other growth hormone deficiency are the insulin growth factor, which I have already told you. These are basically for the growth hormone deficiency. Then we can also perform the OGTT in the patient with the growth hormone deficiency. First of all, we will perform the IGF. Then if the IGF levels are elevated, then we will go for the OGTT, oral glucose tolerance test. In this, basically the 75 gram of the oral glucose is ingested orally in the patient over the 5 minutes in the different with 3 to 4 sips, and the patient is asked to drink the water slowly to avoid any nausea or the vomiting. So if post OGTT the growth hormone levels are adequately suppressed, then no active acromegaly retest if strongly suspected. So these all are basically the suppressive tests for the growth hormone excess, when there is the growth hormone excess. And the pituitary MRI is basically for the pituitary mass. The growth hormone secreting pituitary adenoma will also be diagnosed on the pituitary MRI. Then there is normal hyperplastic gland or the small pituitary. All these things can be assessed under the pituitary MRI. So special testing for the growth hormone, this is just the repetition. Whenever there is the growth hormone deficiency, there are certain provocative tests or the certain stimulatory tests. While in the growth hormone excess is there, then there is certain inhibitory test, or then there is certain test which basically depresses the response of the growth hormone. For that there is the OGTT test is there. And the if the suppression is of the growth hormone is less than 1 nanogram per ml. Isolated gonadotropin deficiency, the patient present with the Kalman syndrome, in which there is basically the hypogonadotropic hypogonadism picture, and the most common clinical manifestation is the cleft palate, and there is the which is mostly diagnosed at the puberty, and the puberty is also delayed in these patients, and they basically this is mostly the sporadic. So the mutant genes which are involved are the CAL1 genes and the CAL2 genes. CAL3 genes are of the autosomal recessive value. Empty Sella syndrome. In the empty Sella syndrome, the Sella testicle is basically widened, and the thin flattened pituitary gland is placed in the Sella testicle, and there is the hypopituitarism, or the pituitary gland, it is not functioning properly. It can be either there is the increase in the hormone release, or there can be a deficiency or in the hormones. The increase present with the hyperprolactinemia, oligomenorrhea, or the oligomenorrhea. These are also the these all are basically the clinical presentations of the empty Sella syndrome, patient with the empty Sella syndrome. The most important is the diabetes insipidus. So this section was basically about the diagnosis of the growth hormone deficiency or the excess, and the certain tests were discussed. And whenever there is the deficiency of the growth hormone, the short stature, you perform the stimulatory test, the stimulation test. These stimulation tests were the first one was the exercise. You ask the patient to exercise. The other thing was the other was the drug. The levodopa drug was administered in the appropriate dose IV. And whenever there is the excess of the growth hormone, you perform the inhibitory test or the suppressive test. For that, you perform the OGTT test, and then there is a respective value for that. Thank you for watching sqadia.com.